Hello dear friends and colleagues, today in this part of the video we are going to discuss how to use intracameral moxifloxacin effectively as well as safely. Initially we inherited this idea of giving 0.1 ml microbolus of 0.5% Moxi in anterior chamber rather just empirically from our retina colleagues. Typically they use 0.1 ml in vitreous injections because vitreous does not have more space and leaking out is not a major problem for them. Injecting intracameral 0.1 ml Moxi is problematic in many ways. Drug volume control is difficult to maintain from case to case. About 20% of the drug remains in cannula's shaft and hub. Leaking side ports will allow early or instant outflow, so about 20 to 30% of the drug is lost out. So only about half of the intended volume actually stays inside the anterior chamber in most cases, and aqueous turnover dynamics were never considered. Please note carefully in this picture that even small variations in the convexity of the piston's plunger silicone rubber tip as well as variations in the inner concavity of syringe's front hub will make a significant difference in the actual volume of the drug. By the way, when we were doing R&D for making UV Glow, which is our UV device for C3R, corneal collagen cross-linking treatment of keratoconus, in 2015, by a lucky serendipity, we accidentally found that moxifloxacin is a fluorescent molecule with lime green glow at 390 to 400 nanometer UVA wavelength. This is our very low power UV glow combined with OmniGlow, which we fondly and aptly named as Moxi Glow. This Moxi Glow helped us to actually visualize the moxifloxacin in real time and also enabled us to record what really happens to it in the anterior chamber. When we inject undiluted 0.5% Moxi as 0.1 cc microbolus, we can see that it remains localized because it is a heavy molecule not readily miscible in rest of the anterior chamber, so the concentration will never be homogeneous or uniform in the anterior chamber, and also it leaks out, 1/3 or more leaks out from the injection site side port, so the final retained concentration will be highly variable from case to case and never uniform in every patient. Also, when the patient will stand up, it will gravitate downwards further and start clearing out faster from the lower half of trabecular meshwork, keeping the upper half of the anterior chamber nearly empty and devoid of the drug. So we will still get one end-off in about 3400 cases even after using 0.1 cc microbolus of 0.5% Moxi, and in most of such unfortunate cases this will be by MRSA or Pseudomonas, because erratic small underdosing of 0.1 ml may kill strepto and P. acne but will not kill the resistant staph or Pseudomonas strains. If we accidentally inject more than 0.1 ml of undiluted Moxi, TAS can occur with moderate to severe irreversible damage to cornea, iris and trabecular meshwork. For many minutes or maybe hours, the concentration can here be as high as 5000 micrograms per ml, damaging the corneal endothelium, iris and trabecular meshwork. Whereas the concentration here can be zero because Moxi is not readily miscible in BSS or the aqueous humor, and since it is a heavy molecule, it has a tendency to gravitate downwards. So from this moment onwards, please give up the 0.1 ml microbolus without giving up the intracameral moxifloxacin. Never, never, never give up giving intracameral moxifloxacin. It is absolutely essential. If we don't use any intracameral prophylaxis, we can have post-op endophthalmitis in about 1 out of 1600 eyes. If we use erratic low dose, we will still get post-op endophthalmitis in 1 out of about 3400 cases, which certainly will be by virulent and resistant strains of Pseudomonas or Staph aureus. And if we use erratic high pulse bolus dose, then we may get TAS. So it is like mountain biking on a steep ridge with post-op endophthalmitis in waiting on the trough side and TAS lurking on the valley side. Or as is a proverb in Hindi, एक बाजू कांटे है, दूसरी बाजू कंकर है. Sharp stones on one side and thorns or nails on the other side of bed with very tight space to sleep at peace. So what is the solution? Well, the solution is to make solution, a diluted solution of moxifloxacin. So we have to carefully understand and learn why and how to make and use pre-diluted Moxi mix in 1500 micrograms per ml concentration. Fortunately for us, in India and India's allied countries, Oromox 0.5% injection from Orolab is available as 1 ml vials, which is an Indian FDA approved preservative-free ophthalmic solution approved for intraocular use. Appasamy Pharma's injection Moxifur is also same 1 ml 0.5% moxifloxacin, that is 5 mg, that is 5000 micrograms of the drug in 1 ml. Additional advantage here is that this is in a sterile pouch like an IOL, so we can take it directly on the trolley. We can choose whichever is better for us and better available. Formula of formulation will be the same for Moxifur and Oromox. Of course, our personal preference is to have a vial which is terminally sterilized in the sealed steam pouch, which can be directly taken on trolley and can be handled by the scrubbed assistant. And also, we need not to worry to disinfect the external surface of the rubber cap with isopropyl alcohol before inserting the sterile disposable needle to withdraw the contents. Injection Oromox or Moxifur is 5000 micrograms in 1 ml. We can withdraw the entire 1 ml in a 5 ml syringe and then add 2.3 ml BSS to it to make a total of 3.3 ml diluted solution. Now this Moxi mix will contain 1515 micrograms per 1 ml, the desired concentration we need. Even after this dilution, it still is identifiable because it looks very faintly pale yellow. But if still there is any confusion in the minds of doctor or staff, we can just switch on the Moxi glow and we can instantly realize which syringe is containing diluted Moxi mixi and which one is containing the plain BSS. Injection 4-quin PFS from Entod is another excellent option. This 0.5 ml of 4-quin PFS injection is containing 2500 micrograms of the drug to be added to 1.1 ml of BSS in another 2 ml sterile syringe to make a total of 1.6 ml, so that now this diluted Moxi mix is containing 1562 micrograms per ml. We can also use IMF eye drops from Days Pharma or Cyamox eye drops from Albert David Pharma, which is 0.5% preservative free 5 ml eye drops. It is contained in an FFS bottle, foam filled and sealed bottle, which is as good as a plastic ampule, which is as good as an ampule of injection. Instead of glass, this is a plastic. It is hermetically sealed without any human touch in the manufacturing plant, so this can be safely considered as an alternative to a glass ampule. We have no financial interest in any of these. There are some caveats in using eye drops as intracameral injections, which are: it should be pure Moxi, not in any combinations such as with Dexa, prednisolone, ketorolac, bromfenac, nepafenac, etc. It should be without any added lubricants, it should be without any preservatives, and preferably an FFS bottle which will be made with zero human touch, which is as good as a hermetically sealed ampule, a plastic ampule instead of a glass ampule. We take 75% or plus isopropyl alcohol, absolute ethyl or methyl alcohol, or pure acetone in a sterile cup and dip the nipple of the bottle for about 2 minutes to disinfect the tip. After which, after couple of minutes when it is dry, the nipple of the bottle is punctured with a new sterile disposable 18 or 20 gauge needle by the unscrubbed assistant, making sure that there is no inadvertent or accidental touch of his fingers to the tip of the bottle. Then now the scrubbed assistant will hold the opened 5 ml syringe with a 27 gauge cannula attached to prevent gravity leaking, containing 3.5 ml BSS. The unscrubbed assistant will now squeeze or milk out 1.5 ml of Moxi into this syringe to make a total of 5 ml, making sure that there is no finger touch during the process. 1.5 ml 0.5% Moxi eye drops is equal to 7500 micrograms of the drug, which is added to 3.5 ml BSS to make a total of 5 ml. That means 7500 micrograms divided by 5 ml. So 1500 micrograms per ml, the desired concentration is achieved. We can make 3 such syringes of 5 ml Moxi mix from one 5 ml bottle of Moxi eye drops. The remaining 0.5 ml Moxi can be used for topical eye drops during pre-op preparation. Thus, we can serve at least 3 patients from one bottle of Moxi eye drops. Please note that after closing the syringe with the piston, we need to gently shake the Moxi mix few times to homogenize it, because Moxi is not readily miscible in the BSS. This Moxi mix is our Brahmastra even against the most violent and most resistant Pseudomonas and Staph aureus. This Brahmastra will kill fungi and inactivate viruses as well. Almost in more than half of the cases, some ingress of blood or corneal or conjunctival epithelium and the surface debris is inevitable. Sometimes it is obvious and visible in the light microscope. Most of the times these debris are not visible, and with that the invisible bacteria have already entered. We have to remove whatever debris and blood cells is possible to be removed, because these areas behind the IOL can harbor P. acne or staph epidermidis. So thorough cleaning of the visco from behind the IOL as well as from front of the IOL is necessary. We insert the Moxi mix cannula from side port, always remaining in front of the iris, and inject the Moxi mix, whirling it and swirling it till the entire chamber is full and the Moxi starts to overflow from this and the opposite side port, and then we hydrate the side ports with the same solution. We can see Moxi going into the corneal stroma around the side ports, and then we check the intraocular pressure to be around 20-25, and this is the last step of the surgery. It is my personal preference and recommendation as well even to do hydrodissection with Moxi mix, going under the rhexis and completing the hydro procedures with Moxi mix so that it is present in the anterior chamber from the beginning of the surgery to take care of any ingressed pathogens right from step 1. Moxifloxacin is such a sticky and tenacious molecule that even after the complete phacoemulsification with so much of fluid turnover, it is still present in the capsular bag fornix because it is absorbed by the cortex. It is my personal preference to make a limbal or slightly scleral entry which is transconjunctival, and after putting visco in the chamber, I put 2 1 mm nicks on each side to prevent the ballooning or chemosis of the conjunctiva. It is also my personal preference to make Moxidex, a cocktail of 1 ml of undiluted 0.5% Moxi, 0.5 ml of 2% lignocaine without adrenaline, and 0.5 ml of injection dexamethasone to be given as 0.1 to 0.2 cc painless subconjunctival injection as the last step of the surgery. With this Moxi cocktail, I always give approx 0.1 ml subconj on each side of the conjunctival wound as the last step of surgery. Thanks to this combination of intracameral Moximix and Moxidex subconjunctival, we could achieve zero endophthalmitis with zero TAS cumulatively in over 200,000 surgeries. We wish the same and pray to and pray for you all as well. Today, on the behalf of entire ophthalmic fraternity, we hereby request Orolab to come out with a 2 ml vial containing 0.15%, that is 1500 micrograms per ml, Oromox PDC. The PDC stands for pre-diluted concentration, ready to be injected in the anterior chamber solution, so that we don't need to do any dilution further. And yes, they should make this in a sterile take it on the trolley type pouch. In the same line, we also request Apasami Pharma to make the same a 2 ml 0.15% Moxifor PDC vials, pre-diluted concentration vials available for us, lowering the concentration from present 0.5% to 0.15% so that we can use it directly into the anterior chamber. Similarly, we also request Antod Pharma to make available a 2 ml 0.15% 4-quin PDC PFS. At present, we are working with one big and well-respected and well-reputed pharma company which specializes in making IV preparations. They are likely to make available 1 ml vials containing 800 mg or 800,000 micrograms of Moxi. We call this as Moxifort. We can add this 1 ml Moxifort into 500 ml BSS pint from the side port, so that this BSS is now going to contain 1600 micrograms of Moxifloxacin per ml. So the entire infusion throughout the surgery is containing Moxifloxacin. And with Moxiglow, we can monitor and confirm the presence of Moxifloxacin throughout the surgery. This is an interesting experiment which demonstrates how sticky and tenacious is Moxifloxacin. I put a drop of Moxi on my palm back at 11:25 am and then kept on working in OPD, washing my hands several times between each of the eye flu infected patients. Now at 4:35 pm, after 5.5 hours of working and washing, Moxi is still there, and now I rub my hand and try to remove it. It doesn't go. It doesn't want to go. Now I take a water wet cotton swab and rub. It still doesn't want to vanish. It's so sticky. Now I take second BSS wet swab, and still it is adamant and persistent. It doesn't want to leave my hand. It wants to stay there. And then I take isopropyl alcohol swab and rub it vigorously, and it still doesn't go. It only fades a little. In fact, it was still there faintly on the next morning when I took bath. Moxi has very, very high tissue affinity. You all also can do this amazing experiment. This video under Moxiglow is taken 7 hours after the surgery, and we can still see that the Moxifloxacin is present in the anterior chamber significantly. It's almost the same amount which we had injected at the end of the surgery. With acetazolamide 250 mg given immediate post-op, We can see moxifloxacin in a fairly significant amount even at the end of 10 hours post-op. Even after 15 hours, we can still see significant amount of moxifloxacin in the anterior chamber. With AVA SR or IOPAR SR, the sustained release acetazolamide 250 mg being given, I have seen fairly good amount of Moxi in the anterior chamber even after 20 hours. Many surgeons use Kitmox Unims made by Centis Pharma, which is 0.4 ml, 0.5% moxifloxacin, which contains 2000 micrograms of moxifloxacin. We can withdraw 0.3 ml of Kitmox Unims into a sterile 2 ml or 1 ml syringe and add 0.7 ml BSS to it to make a total of 1 ml. So the final concentration of which will be 1500 micrograms per 1 ml. These are Kitmox Unims glowing under the Moxi glow. There is a caveat for using Kitmox Unims. Please use Dispo-1 or BD 1 ml syringe which is sterile and individually packed and has detachable needles. We have to discard the needle after taking out the Unim's content and use a new sterile cannula to inject into the anterior chamber. Please never use insulin syringe because they are not individually sterile, not individually packed. They are in a single pack of 20 or 50. They don't have detachable or removable needle. It is a fixed needle system and the markings are in insulin concentration units and not in the ml or cc. Many surgeons asked us, can we use moxifloxacin IV infusion for intracameral use? The answer is a big no for two reasons. One, all IV Moxi always contain 5% mannitol as additive, and two, its pH is 4.5 to 4.8, which is very acidic. Some friends ask me, can 5 ml of Moxi eye drops be added to 500 ml of BSS or single lactate pint like the gentamicin we used to use? The answer is 5 ml multiplied by 0.5% is 25 milligrams, that is 25,000 micrograms. So in 5 ml of eye drops there are 25,000 micrograms of the drug. If this is added to 500 ml of BSS, we shall get only 50 micrograms per ml in the pint. What we need is 1500 micrograms per ml. So we need to add 30 bottles of 5 ml Moxi eye drops to achieve that concentration, or we need 50 bottles of 3 ml of Vigamox to achieve that concentration, and this is impractical. By the way, let me tell you few amazing facts which are food for thoughts. We all know that quinine is the daughter of cinchona plant. Now quinoline is daughter of quinine. In fact, the name quinoline comes from the words quinine straight and direct family line. Now the quinoline has 7 daughters: anti-cancer, antibacterial, antifungal, anti-malarial, anticholinesterase, anti-diabetic and antiviral groups. After fluorination, the quinolines are now known as fluoroquinolones. In nature, the fluorine is the prime giver of fluorescent glow. In fact, the word fluorescence is derived from the word fluorine. Second one is phosphor and the third one is radium. So the fluorescence of fluoroquinolones is thanks to the fluorine present in them. Our teeth, if having high amounts of fluorides, also will have fluorescence and will also glow in UVA, whereas artificial tooth or cap will not glow. The plaques, even on healthy teeth, are having high fluorides and they will glow in UVA, so we can diagnose and differentiate. In fact, this double ring of quinine molecule has natural fluorescence of its own. In fact, by the great serendipity, the first and foremost discovery of the fluorescence itself was done in 1845 by Sir John Herschel from quinine water only. Quinine water's fluorescence was first demonstrated in public in 1850 by Sir G. G. Stokes in a church where the cobalt blue panel of the stained glass window was used as UV excitation filter and a glass of yellow wine was used as yellow filter. It is interesting to learn that almost all brands of immunity booster tonic waters have trace amounts of quinine added to it. Thanks to these trace amounts of quinine, all tonic waters glow under 350 to 399 nanometer UVA light. It is also very interesting to know few other uses of moxifloxacin. At the concentration of 0.25 mg per liter, that is 0.25 micrograms per ml, Moxi can quickly kill mycobacterium, making sputum culture negative in less than 8 weeks. This is much more efficient and faster than the isoniazid and ethambutol. So, along with the rifampicin in Europe, now Moxi is being recommended in place of optic neurotoxic ethambutol and retinotoxic isoniazid. So broad is the spectrum of action of Moxi that US FDA has now approved it also for the treatment of pneumonic and septicemic plagues. So drug repurposing is absolutely ethical and also a right of physicians and surgeons if the primary safety of a molecule is well established. And it is legally allowed as well. Melting point of moxifloxacin powder is 325 degrees centigrade and boiling point is 636.4 degrees centigrade. So it can be safely autoclaved if you wish to do that. We routinely autoclave Oromox vial so that the scrubbed assistant can handle it directly on trolley because it is not presented in a sterile pouch, and we don't need to worry about disinfection of the silicone rubber cap with isopropyl alcohol before inserting the needle to withdraw the contents. Here, injection Moxifur from Apaswami Pharma has an advantage that it is presented in a sterile pouch. Many eye surgeons have often asked me this doubt: when we autoclave a glass bottle or a vial, external surface will be sterilized by steam and temperature. Will the internal liquid also be sterilized? Let me explain you this from physics and thermodynamics point of view. In our routine autoclave, which takes 25 to 45 minutes time for a full sterilization cycle, the liquid inside the bottle also boils at 131 degrees centigrade and becomes a equal pressure steam as the external steam of the autoclave chamber. Both are in the equilibrium pressure and temperature. If it is not in equilibrium, the glass bottle will either explode or implode. So here the outer surface is sterilized by the temperature and pressure of the autoclave's water steam, whereas the bottle's internal surface and internal contents are sterilized by the internal steam which is generated from the solution. And when it cools, that internal steam becomes condensed and becomes water again, so that the concentration of the drug is never altered or affected, because that internal steam cannot escape out. But in case of super fast flash autoclaves taking only few minutes, there is not enough time for bottle's internal water to become steam of equal pressure and temperature. These are only for surface sterilization, especially for metallic instruments, and not for bottles or vials. It is very interesting to know that the molecular or molar weight of water is 18 grams per mole. Of mercury, it is 200.5 grams per mole. Of lead, it is 207.2 grams per mole, whereas the molar weight of moxifloxacin hydrochloride is a whopping 404.4 grams per mole. So, in full 100% concentration, the Moxi is 22.3 times heavier than the water and about 2 times heavier than the mercury and lead. This is a video which demonstrates two facts. Number one, Moxi is not easily miscible in BSS, and number two, it has much higher molecular weight than the BSS, so it tends to gravitate downwards. In this BSS pint, we have injected Moxi via the side port of the pouch, and we can see that Moxi does not want to mix with the BSS. Unless patted, shaken and whirled, it does not mix. Same thing happens in the anterior chamber when we inject 0.1 ml undiluted microbolus. So, if you are still using 0.1 cc microbolus, please stop from this very moment and switch over to the diluted Moxi mix full injection of the anterior chamber. Under the 395 nanometer UV, Moxifloxacin has a sort of a divine glow, very reassuring divine glow. Which always reminds me of the northern lights, the polar lights, the divine aurora borealis. Also, the green band of the Indian national flag always reminds me of the Moxifloxacin's glow. To summarize, microbial ingress is inevitable, if not in all, in many cases of any type of penetrating intraocular surgeries, even in the cleanest OT environment. It is beyond the control of the surgeon. We cannot leave the patient's eye at the mercy of ingressed microbes, so we definitely and certainly need intracameral broad spectrum and safe antibiotic as prophylaxis. It is unethical and now also not safe legally not to use intracameral prophylaxis. ICMP, the intracameral Moxi prophylaxis, is as important and as essentially needed as autoclaving of instruments and linens, wearing cap, mask and surgeon's proper attire, wearing sterile gown and gloves, and skin prep by betadine, etc. And the ICMP is much more important and preventive than having a modular OT with SS walls, antistatic floor, laminar airflow with HEPA filters and AHU, the air handling units, and positive air pressure in the OT. Pre-diluted intracameral Moxi safety from cornea and especially its endothelium, iris and uvea, trabecular meshwork and retina points of view has already been proven beyond doubts in tens of millions of eyes across the world by more than 100,000 surgeons who are using it, and it is in use since more than 18 years. If still in doubts, you can read this study and all its references. In fact, this group has used Vigadexa, the preservative-free combination of Moxi and dexamethasone from Alcon. Due to some mythical phobia, still there are many eye surgeons who still are fence-sitters and not using Moxifloxacin intracameral. We urge and request them all to start using intracameral prophylaxis of Moxifloxacin prudently and with positivity, because future possible harm of not using it is far and much more than using it. There are many eye surgeons who inject 0.1 cc undiluted Moxi and then immediately wash it out with plain BSS. And there are some who use 0.1 cc of 1/1 diluted Moxi and many who wash this out too. All these are variable and underdosing wrong practices. They are in waiting for MRSA or Pseudomonas endophthalmitis. As prudent professionals, we should come out of fake fears and mythical beliefs in the bright light of scientific facts. So, with the Sarvaguna Sampan Moxi mix, Moxi gun in our hands, we can be as sure, secured and confident. Ian Fleming's 007 Bond, the James Bond. And forever say never again to the endophthalmitis. Here, with deep and soulful gratitude, we dedicate this video series to the pioneer Moxi guru, the most respected Dr. Steve Arshinoff. Along with Dr. Steve Arshinoff, we were recently honored with gold medals and felicitated by Saffron Safa Pag, the Indian traditional headgear of valor and honor, for our work on zero endophthalmitis by the Bombay Ophthalmic Association. Of course, with the Moxi Glow, there are many bonuses also. We can use Moxi eye drops for corneal staining instead of using sodium fluorescein. Moxifloxacin can be used for corneal collagen cross-linking instead of the riboflavin, because Moxifloxacin produces the same reactive oxygen species in stroma as riboflavin to induce corneal cross-linking, collagen cross-linking. But this is a different topic for our future video. We can also use Moxi Glow with Moxifloxacin to check the fitment of RGP and Rose K contact lenses, especially for keratoconus, and also for regular and irregular astigmatisms. When the human lens protein undergo oxidative changes, the crystalline protein of the lens accumulates tryptophan and beta-carbolin, which are also fluorescent to a certain extent. To detect or demonstrate the presence of cataract, just shine the Moxi glow and the cataract will shine like radium or phosphor. It's a very nice demonstration to patients' relatives to show them what is the cataract. It can also be used to test the photochromatic glasses. For photochromatic glasses, we can really measure how quickly they become dark. We can also check the UV blocking lenses. Moxifloxacin will glow green, but if the UV blocking glass comes in between, the glow will be cut off. This child had congenital nasolacrimal duct block in left eye. 20 minutes after putting Moxi eye drops, when we shine the Moxi glow, we can see that the drug has passed into the nose on the patent side, while the drug is retained in the lacrimal lake on the blocked side. This is good for us for confirmation as well as good for demo to parents. With a minor modification in the fundus camera, we can also do retinal angioscopy and graphy by using intravenous moxifloxacin in place of intravenous sodium fluorescein. In the next video, which we will upload after few weeks, we will show many other important aseptic and antiseptic measures to be taken to achieve zero endophthalmitis, as well as we will also show how you can make your own Moxi glow. Dear friends, till then, Jai Hind and Vande Mataram. I am sure that now onwards you will also now see Moxi's glow in our flag. Wishing you happy surgeries and happy independence from endophthalmitis. Please forward these videos to your friends, especially the young eye surgeons and residents, so that they all can kick the possibility of endo out of their OTs. This will also be a noble social service at your fingertips. Thank you very much for being with us so long. Thank you very much for your kind attention and patient listening.